Dr. Guo, we cannot see your,
Hi.
cannot see your, oh, we
Hi,
just
Dr.
see your
Wang.
face.
I have heard you.
I'm Dr. Wang.
Hi, Dr. Wang. Nice to meet you. You are in Korea now?
Yes, just came in early morning, 5 o'clock.
Okay. Thank you very much for my left case moderate.
So there are many friends on the stage. So the Eberhard and
Because I cannot see the picture from the Korea, so I just read the list. There is Dr. Kruber. Good morning.
Good morning.
And Dr. Hall. Morning.
Good morning.
And yeah, my good friend, Dr. Wang. How are you?
fine.
He came in
Okay.
early, so he's a little tired.
Looks fine.
Yeah, no. We have completed the first one. This is the second case. We do this today.
Wonderful.
Okay.
Okay.
Keep going.
So let's begin. I will introduce my team for all. Thank you for the meeting. Give us a chance to give the left case for the meeting. Today we will present pure aortic regurgitation left case for you. And first of all, I will introduce my team for you. And from my left hand side is Dr. Peng is my TEE moderator. The second one is Dr. Liang is my anesthesiology for the monitor this case. And my partner, Dr. Liu and Dr. Chen and Dr. Shi is my partner. We will do the left case together. And Nurse Ni and Nurse Chen will assist us to do the valve preparation and to do the left case together. Thank you very much.
Thank you.
And then I will introduce the case information for you. Okay. Can you see the presentation there?
Please show us the slide, patient information.
Please show the slide. 切换一下. Okay. Okay. Today we will do the left case is a 77 years old male, and this patient is suffer from the very severe pure aortic regurgitation, and the TEEC shows the EF only 46 percentage. Before the operation, the patient without any mitral valve insufficiency, without cabbage disease. Next one.
Is James in the room?
What?
No, we're just talking. Sorry about, I don't want to interrupt you. I'm just asking here the audience.
I'm sorry. Okay. This patient is combined with hypertension and with a very long smoking history, and is combined with the COPD, hydrothorax, and the TIA before the operation. And with this patient before the operation, there's compliance the unstable angina, and other problem is palpitation, dyspnea, and cough, and others. Edema for this patient is a little bit severe. And we can see from the patient, we can evaluate the risk score is 8.9 percentage from an STS score. And shows the echo have shown it's a very severe aortic regurgitation and without any valve calcification. And before the operation, we do the catheter finding that the coronary artery is okay. And we can see the CT scan analysis. We can see the diameter of this patient is 28.2. And you can see we were for this patient we will use a G-valve device to do, and oversize only we will use a 29 G-valve, and oversize only 3.6. In fact, so for the most of the cases, we do not use oversize to do the procedure because the G-valve is very special design for this. It's very special design. We can do the TAVR procedure without any oversizing. And the left case, we can see MDCT analysis. So we can see it's without any calcification. And the STG is 31.2. And the left coronary and the right coronary is perfect. It's 11 and 12 and 20 millimeter. And this patient we will use a TA transepic axis. And we will use a G-valve to do this procedure. So for the teaching part for this case is we use the J-valve to do the TAVR procedure for the aortic regurgitation without any calcification tissue and a little bit dilated left ventricle. And the device selection, we use the TA transapical axis using J-valve. And center, we will pay more attention to the processes implementation and the valve performance evaluation of the operation. That's all information for this patient. Any question? Thank you.
No, I think this is very, very interesting. Thank you for showing us this. Obviously, there is a lot of interest in the J-valve, in approaching percutaneously aortic insufficiency. So we are all very grateful for this transmission, and we are very much looking forward to following your various steps. Be patient with us because not many of us are familiar with the J-valve, and explain maybe what you do so we can follow you a little bit better.
Okay, thank you, Dr. Kerber.
Thank you.
So 那个植入器装好了吗 ？OK， 把植入器拿过来。待会我们的 camera 应该对这个植入器哈，我要讲一下这个植入器。Okay, before the operation, we will introduce this device for all of you. You can see this device is a very classical transapical design. We can see that this device a little bit larger transducer is a 13-3 branch transducer from the transapical going to the heart. We can see the valve is just closed in the tip of the device, and at the second stage we can see the anchor a little bit short. And we can see there are 4 keys. We can monitor this device from the key 1, key 2, key 3, and then release this valve. And then we close all the key and pull back the device. The operation will be completed to get all. And we can see from the 看转到那个 DSA. Okay, we can see the DSA from the DSA. We can see the valve. Okay, 听着. At the tip of the device, this is the valve. You can see 3 anchors in the sheath. There are 3 anchors. 我转一下，看一下。We can just rotate the transducer. We can see the 3 sheaths, the 3 anchors holding in the sheath. Okay, this is the device. Any question for this? Oh.
Sorry, what's the size of the device again?
29.
How many frames? 29. Okay.
Yeah, because you know the diameter of this patient, we have analysis from the CT scan is 28.2 millimeter.
Okay, thank you.
Okay. If there is any question, we'll begin this penetration from this way. We can see. Okay, 把镜头对这儿。
Hi, Dr. Guo.
Hi,
So
Dr.
I
Wang.
know you are very good at the transapical way to do the TAVR. So if for this kind of patients, if we do the transfemoral, so how do you think for this patient?
You know, for the device available in the marketing for the in the world is very there's no device can be used in the aortic regurgitation. So because you know most of the device should depend on the calcification tissue to hold the valve in position. But so I don't think that there is a big for example the other device not available in marketing can be used in the aortic regurgitation. Maybe some device can be used off-label to do the aortic regurgitation. It depends on some tissue calcification or thickened tissue to hold the valve in position. But you know this case with there's not any tissue in a thickened tissue or the calcification tissue can be used to hold the valve in position.
Hi, Eberhard. I think still for some kind of patients, like the small annulus patient or the LVOT is very small. For this kind of patients, if we do the self-expanding device, it should be okay from transfemoral artery. So what is your experience? Do you have any experience?
Dr. Wang, you have some cases use the venous A device to do the aortic regurgitation. It's a very good result. but I have any experience to do this that device to do the aortic regurgitation.
No, I mean, I have only experience with a Jenner valve in small annuli, which is basically, you know, a valve type like the J valve. But to be honest, I'm not very convinced that we are doing the right thing at this point, using a self-expanding valve, a core valve or any other valve, because, you know, the danger of migration is high. We always have a second. I mean, we have published data, we have personal experiences. There's really no prediction of whether we have a good result or not. So I don't think at this point, at least, that with any of the present valves, unless the annulus is really small, we will have good results with the existing valves that are here. That's why we are so excited about looking at the J valve with your experience there. And I think you have experience too, Jan, right?
Yes, yes.
Yeah.
Not so many as the Dr. Guo, actually. He's a pioneer in J valve in China.
Yeah.
So just one more question is, what is about your what is about the limitations for? I mean, what is you think about the contraindication for patient for J valve?
For J valve? For J valve, the J valve there is many. I think it's very many characteristics that can be used to the TAVR procedure. You know, there are 3 anchors here in this device. The 3 anchors can hold the valve close to the stent. So sometimes the anchor can make the patient avoid of the coronary occlusion. And second, the valve can use the native tissue to help the valve hold in the position. So even because the 3 anchor cooperate with the stent together, we needed to oversize so much. So for the patient who have follow-up, the pacemaker implantation rate is very low. In our center, the patient pacemaker implant rate only 3.9% in our center. So it's a very low it's a very low pacemaker implantation rate. And second, we have observed over 300 cases in our center. There's a very few PVL exist after the operation. Only 0.8% people can be observed the moderate PVL, but most of the cases without any PVL, or only mild or only mild PVL exists.
So any contraindication about the ejection fraction is too low? If the ejection fraction is too low, it should still be okay?
I think the contraindication for this device, based on my individual experience, only maybe we cannot there may be some thoracic closed, or sometimes the malformation of the thoracic skeletal structure. I think more especially for those patients with combining with mild infarction at the anterior wall of the left ventricular. At that time, maybe you penetrate this device into the heart is a little bit hard. But we have a very few cases in experience. We do the myocardial infarction cases before the operation. But we have maybe we dilate the penetration site a little, several times later. We can penetrate this device into the heart too. So I think maybe this is a semi-contraindication for this device is maybe mild infarction at the anterior wall. But we have seen some thoracic cavity closed patient. I think it's very difficult to do this procedure.
Is there a transfemoral version of the J valve?
Yeah, in the future we have we can waiting for the edition of the transfemoral. But no, they're still not available in China.
Okay.
There are only very few cases in United States. We have to do a very few cases to do the transfemoral.
Very good. Excellent.
Okay.
So keep on going. Good.
Okay.
Keep going.
Okay. Let's go in. You can see this. Okay, let's wait. You can see this is the incision, only 3 or 4 centimeter here, and you have to dilate a little bit this here. We can see the apex of the heart, and we do the 2 suture here to make a hole here, and about 1 centimeter diameter. It's okay. With you can see there's not any bleeding, and the heart construction will not be influenced very much. And first of all, we have to go into the pigtail. You can see the 装到那个 DSA. We can put the DSA. We can put the pigtail to the annular plane, and then we will penetrate the apex. OK， 你过来嘛，好，那个是看不见了。And first of all, we will use the penetration from the apex going to the heart.
We see a beautiful
okay,
back
we will
now.
make sure with the TE to make sure the guiding without influence each other with the tender of the mitral valve. You can see the echo.
Yeah, very nice.
Yeah, because sometimes you have to pay more attention. If the guiding with influence with the mitral tender, we will pour out the guiding totally and then penetrate again. Okay. And then we pour out the guide one with the MAP going through from the penetration with the guided one to the descending aorta. Yes. Okay. The guide one. Oh, wait, no. 我进了啊。
Hi,
Okay.
Dr. Guo.
Hi.
So how do you select the puncture site? Before you select the puncture site, do you use the finger test?
I think we can evaluate the annular plan before the operation use the CT imaging, and then we select a site just to a right angle from the annular plan. I think is the best one. But you know, sometimes because it was be limited by the intercostal space, sometimes we can select angle just to close to the right angle to the annular plane. I think is better. But sometimes we have to avoid to damage the coronary artery. 哎，太大了这图像。OK， 往上调大一点，调到8嘛，不要这么大。And we will make sure the tip of the guideline to the femoral artery, I think is better. 这个大小不对呀。OK。OK。And because you know, for the most of all of the aortic regurgitation, we needed to use a balloon. So we just use a 16-French penetrator to dilate the penetrator site a little bit, and then we can, and later we can go into the transducer very easily. This dilator is 16-French only. 我进去了啊。And when we complete the 16-French dilator into the heart, and we will do the root angiography to show the annular plan. 角度。这是多少倍数？这倍数不对。OK。OK。好。做一下。 You know, we cannot see the valve just just like the stenosis. So we just use the pigtail to make sure where is the non-coronary sinus, and then we will do the angiography or root angiography for this patient. So,
Angio.
The angio. 什么情况？
抬高一点，这个屏幕抬高一点。
OK。不，把这个压下去一点，把高压棒压下去一点。
不能太低了。
OK， 重新照一下。
重新找。
Okay, we will do the angiography again because you know some mistake here. You can do. Okay, so you can see from the angiography, you can see the 3 sinus in the same line. The pigtail in the non-coronary sinus, and we can see the right coronary sinus in the middle of this image. And we can see the left coronary sinus at the right side of this image. Okay. Because you know this patient is combined very severe COPD, so the image cannot be shared very clearly, just like a very thin people. Yeah. Okay. 帮我好了吗 ？Okay， 等一下。Okay, we were going to the transducer, and we are pull back the dilator. And you can hold this guide with the 2 fingers and to pull a little bit on the surface of the heart. You can avoid very severe bleeding here. Okay. Okay. So and now we can lose the suture a little bit, and to make the transducer going to the heart a little bit easy. So it's a big transducer. Okay. Head Weber. Okay.
Hi, Dr. Guo.
Hi.
Is it better to put the pigtail in the right coronary sinus? Is better or in the non-coronary sinus?
Maybe.
Maybe in the right coronary sinus is better to guide your direction.
You mean so we just put the pigtail in the right coronary sinus? And
It's the pigtail.
Yeah.
So not the pigtail in the non-coronary sinus, above the non-coronary sinus. It's better to put in the right coronary sinus, maybe better.
拉下来重新再造一枪嘛，那就。Dr. Wang, you mean we will angiography again?
Oh, no. I mean, when you do the angiogram, it's better to
put
pigtail
I know.
in the right coronary sinus, because right coronary in the middle is better for your guidance.
Yeah.
For guiding
you can see we have penetrated the transducer into the heart, and then we will fur a little bit to go up to the ascending aorta. And you make sure the anchor to totally upper to the annular plane, and we can open the key one. You can see we open the key one, the sheath fur back a little bit, and the anchor will open. I 没打开了，图像不对啊，老陈。这图像不对啊，我的有个键没打开，发现没有
？So you position them above and then pull down?
Yes. Pull back.
Yeah.
Pull down. But you need to make sure the 3 anchors in the right position.
这样的方向调一调。这个
不行啊，为什么有个定位键没打开呢？
So that's way up in the ascending aorta, right? Michael, do you know the valve?
No, we are about to start with the program. Yes, I have not used it yet.
3颗的不是太好，3颗，也许我们下去不行照个影。我觉得这个位置还可以。
是吗？
It's kind of a self-alignment of the valve, or do you have to turn it in a specific way?
You have to turn a little bit. But actually, Dr. Guo has a lot of experience. Actually, I think if somebody without much experience, it's better to enter the angiogram guidance or enter the TE guidance. I don't know.
怼的这个定位键。
So what's the criteria now?
有个定位键没打开，
To
什么
deploy
回
the
事？
valve. 不着急。
Make sure the 3 anchors in the 3
Yeah,
the
because
common
you
sinus.
the one you can see the one of the anchor cannot be opened very well.
I actually don't see it, but
We will adjust a little bit.
So you want to retriever?
No, we cannot retrieve it again.
Okay. So why
Just
why
to make sure.
why don't you do the angiogram to guide?
so are there
No,
3?
because we can see one of the anchor just very close to the stent, so we have to make sure going to the sinus very well.
Are there 3 anchors out now?
Yeah. 就是有个定位键没打开。
周刊
It looks like it, right?
No,
No.
especially the left, to the very nearby to the left coronary artery, left coronary sinus, the anchor cannot open very well.
这样子还可以，
Maybe okay. 等一下。
因为它这个
How do we know that the position is correct or not?
Yeah,
Okay,
that's why.
okay, we will angiography again.
Yeah, now they're doing angiogram.
上来。打吗 Okay, angio.
还可以
I。think it's okay.
Yeah, I
But
can,
the shapes of the left anchor is not so good, I think.
So why it's not so good?
I don't know. Sometimes maybe with the tissue of the valve will influence this valve
you
a
do
little
this.
bit.
Do you do this in one position, or you change the position of the imaging? The
Yeah, we
image?
have tried several times to make sure the valve going to the sinus very well. I think no, it's okay. 来回放一下刚才那个 angiography.
回放刚才电影，
I think it's okay.
If it is available, could you show us at this time showing the T transverse fragile image?
现在
我已经放下来了。
好，现在
OK，你 T1看一下它那个 angiography，它那个定位键怎么样？
For the accurate position of the anchoring in each sinus.
How do you know?
So why do you
You
think
know, for most of the situation, the TE cannot see, especially when the device into the annular plane. The angio TE cannot show the device very clearly. 来，好的，把那个 DSA 把那个超声探头退回去。跟旁，
准备放，
那两个就可以放嘛。我猜。
觉得可以。
Okay, and we will deploy the valve. Okay, you can see the valve deployed totally. And you know this valve is a self-expanding valve, so we have to just waiting for a little bit of time and to make sure the valve expansion very well.
Yeah, yes. So
And now you can see from the monitor, the diastolic pressure increased very greatly. Before we deployed the valve, the diastolic pressure only 40 and to 50. Now it's increased to 60 to 70 milligram.
well, diastolic pressure looks nice.
Yeah. I think the shape is very nice, but we're just waiting for a few minutes to make sure the valve open very well. 可以吗，超声？ And you can see from the echo, 把 echo 调到最大。Echo, okay. You can see from the echo the valve in position very well.
Yes,
And the color.
very nice.
Yeah, without any PVL and
Beautiful, at least.
short plan. 短轴。And
So
we can see in the transverse plane the valve is cycle and the color.
Very nice, very nice.
Hi, Dr. Guo.
Without any PVL.
Dr. Guo.
Hi, Dr. Wang.
Hi. So why do you deploy the device so quickly? Is there any technique?
Because the valve, you know, if you deploy the valve very slowly, the valve will sometimes to come out by itself. So I will to release the deployer very quickly. The valve can be holding the position where you want, and to make sure to immigrate a little bit.
Okay.
I think it's okay.
So because you don't pace the patient, you don't do pacing for the
We needn't.
Yeah,
We
okay.
needn't.
That
We
is
never
good.
use it to pacing to deploy the valve. Even if you can see the valve, we need it for the aortic regurgitation. We need the pacing. So sometimes we needn't to use the pacemaker before. We just to prepare the castration from the transfemoral vein. And if we needed to implant the pacemaker guide Y, we just to go into the from the transfemoral vein to pace the pacemaker one very quickly. Okay, Dr. the one we were to pull out the transmission, the transducer. Okay, 我知道. And then first step, we will close the key 2. You can see the second black cord will go up to the ascending aorta. We just rotated the key 2. And then we close the key 3. You can see the 2 block were closed.
So do we do an angiogram?
I think I were to pull out the transducer, then we angiograph again.
Okay. So when you
Okay.
when you deploy the 3 clasps, do you change the projection in order to make sure they engage in the sinuses? Or is this kind of a self-alignment?
Yes, I never see
No,
you
I think it's
change
not
the
necessary.
projection.
Before we go into the device, we have to make sure that 3 dive device in the just in the plane and the 3 sinus where we can see very clearly. We just make sure that 3 anchor to overlap to the image of the 3 sinus, and I think it's okay.
Okay.
完全看不清楚，这图像好差。
讲久了，有点问题，
Okay.
介绍机器有点问题。
And then we'll pull back a little bit the transducer to make sure without any resistance.
有点问题，有点问题。
And then pull back the valve. You can see we just close the key 1, and then we can pull out the transducer. Make sure.
Okay.
Not. Okay.
就出来了，
猜一下，猜一下。
倒是出来了。
OK，
倒是跑出来了。
没事没事。说一下。
你给我们解释下这个。
好，来，然后那个。
有点问题。
Hi,
Okay.
Dr. Guo. Dr. Guo.
Dr. Wang, you know,
So-
today the DSA machine a little bit problem. You cannot see the picture very clearly. I'm so sorry.
But it's okay. It's a very good. All right. I think that because you have a much experience.
The first case, the DSA is very well.
Okay. Because you have a much experience about the procedure, but for the beginning, for beginner, I think maybe they need to change the projection to make sure the 3 anchors in the right position.
Okay. We're going to the MAP to pull back the guide 1.
还是担心这个 anchor 位置。
Yeah.
If we know how to place the accurate position of the 3 anchoring in each sinus, the system looks like technically quite easier.
So I
More
think,
that the operator, the easy to use in an operator. Did you have any experience of the embolization of the valve in your J-valve system?
I'm sorry, pardon?
How many? Did you have experience of embolization or migration of the J-valve?
Yeah.
How many?
At the beginning, we do this procedure. Sometimes we select the valve a little bit small. So when we deploy the valve fly away to the ascending aorta. At that time, we just pour the valve down to the descending aorta and to find a good position to hold the valve there, and we put another valve going to the way.
What is the factor to avoid such kind of the migration or embolization of the J-valve?
I think especially for the aortic regurgitation, the CT scan is very dependable. We will select the 25% of the face and to analysis the annular. That 我们做一个 angiography. And we will angiograph again to make sure the valve whether the position okay. Okay.
Very nice. Very nice.
信息没有了。
Congratulations.
Thank you. 信息不对。
睡啊，颠倒。
And just Dr. Wang,
Hi, I'm here.
please waiting for a few minutes. I will close the penetration site. A little bit of bleeding here.
Okay, wonderful procedure.
Yeah, and then we will discuss the procedure. After we complete the valve implantation, I think we will to close the close the penetration site as fast as we can.
机器上问题。
May I ask one question? I'm Dr. Ra. When you pull back the device, is there any experience of anchoring and the ankle-related injury to the sinus before? Any incidents?
Yeah, when you pull back the transducer, you should to make sure without any resistance, and to make sure the transducer without to pull back the valve going to the left ventricular. You know, the valve just hold there a little at the beginning, so you should pay more attention when you pull back the transducer. 那个信息不对。给我个针，给我一针，给我一个针。4.26， 3.26也行，快点过来。Okay. Okay, I think it's okay. Dr. Wang.
Hi.
I'm sorry. Hi.
So the just now the question is about how many patients, how many percentage of patients maybe damage the coronary sinus among your patients? You have done so many.
Damage the coronary sinus?
So how many patients?
We haven't any case to damage the coronary sinus.
Coronary sinus. No patient.
Yeah, you know, because the anchor is a curve. Instead, it's not a very sharp tip of the tip of the anchor is a curve. So it's very safe to avoid to damage the coronary sinus.
Okay. So what is about the thrombus rate? The thrombus
rate?
Among your patients?
Based on my individual experience, only 3 cases, and we have completed over 300 cases in the past. There are 3 cases to fly away to the descending aorta. We do the valve again, and for sometimes if you cannot to pull the valve to the descending aorta, you have to open to transfer to open the heart, open the chest to pick up out the valve.
So what is the ideal candidate for this J valve insertion for pure aortic regurgitation? Ideal candidate? Or
Ideal candidate?
Yes.
I think the best one is I think if there is a little bit of valve thickened, I think I very like that kind of cases. But if the valve without any calcification or any thicken, maybe we should pay more attention to the valve to hold in a position very well. Sometimes you cannot, maybe if you pull the valve a little bit, maybe the valve will thrombose.
So you mean the pneumatic valve is the much more convenient to use this technique? Pneumatic aortic valve.
I think it's okay. We have many experience to use the valve in the pneumatic valve because there is some tissue the tissue, some second tissue or calcification there will be very helpful to make sure the valve in position very well. 老陈，你跟他说一下呀。我这儿在缝这个切口。
OK，好，他们有问题。
Dr. Chen, and my partner Dr. Chen will introduce this valve for you.
Any question? Yeah.
你讲一下这瓣膜吗？
What about the long-term outcome? How many years did you follow the patient after the DJ valve?
We have followed up the patient over 5 years. From the 2014, we implanted the first case in our hospital in China, and then from the first case till now, we have followed up all the cases in our hospital. Or for some of patients, we have over 5 years follow up. I think there's no any cases the patient come back because of the valve degeneration. For most of the patient, I think we follow up is very good.
Just a question, is there any plans to build this valve for transeptal approach?
Yeah, the J-valve company have planned to progressive this device to the transfemoral cases. I have discussed this question before the operation.
Yeah.
But till now, there's no clinical use in China. There are very few cases in Canada and in USA. They have do the transfemoral approach to do the aortic regurgitation, use the J-valve procedure.
But
use
not
the
the
J-valve
transeptal.
Not transeptal.
No, not transeptal. It's only retrograde.
I'm sorry.
Transfemoral,
I'm
yeah.
sorry.
Yeah.
Can we use it in pure AS with thickened valve or mixed AS-AR?
Sure. This valve can use in the aortic stenosis, even if bicuspid valve. We have over 45% cases is aortic stenosis in our hospital. Use the J-valve device.
Would it be more difficult to do with thickened valve?
Easy. I think the aortic stenosis is more easy than the aortic regurgitation.
Oh, okay.
Because sometimes if you have enough native tissue to hold the valve in position, we need them to make the very precise position before we deploy the valve. We just to make sure the 3 anchor to attach to the native tissue, and then we open the valve. I think the result is very good.
Well, you know, of course, I don't have any experience, but my thought is if you have small sinuses, if you have combined disease with calcifications, you know, the ideal situation is obviously with large sinuses and no calcification, so the anchors can engage in the sinuses. But if there is kind of constrained sinus with increased calcifications, I would assume at least there's a little bit of a drawback.
All right, I think you're right. Hi, Dr. Guo.
Hi.
Just now you mentioned about even the devices good for the patient with a bicuspid aortic valve stenosis. But do you know that for the type 0 bicuspid aortic valve, especially there are only 2 sinus, but you have 3 anchors.
Yeah.
So
It's a very good.
how can you say that?
Yeah, you know, some bicuspid cases, the coronary artery from the 1 sinus, and some of the other bicuspid is the 2 sinus from the coronary artery. So if you found the coronary artery, the right and the left coronary artery comes from the 1 sinus, you just make sure 2 anchor go into that sinus, and this 2 anchor will avoid the tissue, the native tissue to occlusion the coronary sinus. So into the bicuspid, you just put 2 anchor going to 1 sinus and another anchor to another sinus. I think it will be very good to deploy the valve.
Okay.
But unfortunately, if you put the 2 anchor going to 1 sinus, maybe after the operation, you can see the shape of the anchor will be a little bit maybe not so beautiful. So will be to mirror the shape a little bit more. Yeah. But the position of the valve were very good.
Is there any contraindication? I mean, just the ascending aorta dilatation like this. In that case, is it okay for this your technique for ascending aorta dilatation?
This patient ascending aorta dilatation is 46 millimeter.
Yes.
I think it's okay. We need to deal with the ascending aorta. If the ascending aorta diameter over 55 millimeter, we'll do the ascending aorta repair or replacement from the surgery, open surgery.
55, more than 55.
More than 55. For this patient, only 46. Okay.
46. Good.
能不能把昨天那个调出来一下？
他们人不在，算了。
Okay, Dr. Wang, I were to select the case yesterday. We have do aortic stenosis. I will show the procedure of this. Wait, without?
Huh?
Oh, I'm sorry. We cannot. The image have disappeared.
怎么回事呢？
Okay.
Okay.
I'm sorry.
Okay.
Okay, any more questions?
So how many cases you perform this procedure, the J valve? How many
In
cases?
our hospital, over 300.
Over
cases.
300. What is the main pathology of this, your case, 300 case among 300?
Over 60% people is suffer from the aortic regurgitation.
By rheumatic or?
Rheumatic about 5 to 5, maybe 5%, 50% people comes from the rheumatic valve disease. You know, because in China, especially in Southwest China, the rheumatic valve disease per incidence is a little bit high compared to the other regions.
Okay. Wonderful procedure.
Very nice.
Thank you, Dr. Wang.
Excellent.
Are we done?
Excellent.
Okay, thank you very, very much. This was a very impressive and successful live demonstration of a new valve. Thank you for your patience, explaining things to us and the various steps. And congratulations to an excellent result for your patient. Thank you so much for transmitting to Seoul today.
Thank you, Dr. Koo. Thank you, Dr. Hong. Thank you, Dr. Wang. Thank you, everyone.